need us to reapprove the minutes?
I don't believe so.
Okay.
Joel, could we get confirmation from you that we're okay to?
I would just do it to have it on the recording, just in case somebody says, hey, you didn't approve the minutes and an OML violation.
Okay, I apologize. Thank you.
No, not
happy to do so. So Chair Johnson, I've already read the minutes. I would be happy to make a motion to approve them.
Terrific. I have a motion. Do I have a second approval for the minutes? Maybe from Angela Nichols, potentially.
Angela
No
Nichols.
worries.
Sorry, I second.
Wonderful. All in favor say aye.
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 All right, motion carries. Minutes are approved officially on the recording this morning. Thank you. With that, we'll move on to agenda item number 4, which is a presentation on the barriers and facilitators of implementing drug checking services with spectrometry devices. Mr. Schoen, I believe we were interested in bringing this to the table, and I'm really thrilled today that we were able to get a national expert in Dr. Tracy Green from Brandeis University, who will be able to talk about some of the work that her team has been able to do out on the East Coast and looking at sort of the barriers, facilitators, pros and cons around this.
I too am very excited. I'm looking forward to this.
Yeah, wonderful. Dr. Green, the floor is yours when you're ready.
Great. Thank you all for the invitation to come and talk to you, share a little bit about what we've been doing in Massachusetts and a couple other states. I'm assuming the slides are, you all have the slides, I can advance them. Perfect. Okay, thank you. But just to reflect, I don't have any conflicts of interest to disclose, but this work, for what it's worth, is funded by federal funding from the Centers for Disease Control and Prevention, as well as from SAMHSA and from the Commonwealth of Massachusetts. So just to share that. So I think based on the request to come and share what we've been doing, part of that is the rationale that you may very well know, and maybe a little too well, that this drug supply currently that we are living with at this moment in history is extraordinarily toxic. We know from, as an epidemiologist, we see from the medical examiner data that drug supply tends to be a major determinant of drug-related death in our moment in time, and that if we can know the content of a drug, then we can inform our public and policy and as well as also behavioral responses and how people individually respond to the substances that they know about, safer decisions on where and how they use, if they use a substance. But for the most part, we know this information way after the fact, after a lot of harm has already come to a person or a family in their community through death and hospitalization or arrest, data that often are not shared publicly. Some states have a requirement to share them publicly, but that still can happen much later after the fact, where it can be hard to shape our current responses. So other approaches that some states have taken or some counties have taken to expand and improve the toxicological and forensic lab infrastructure are worthy, and absolutely this improves the court processes and other public health measures for sure. But drug checking is special because as we'll be talking about, the remnant drug and the more frequent testing we can do is really important and gives more real-time information to the community. But it also risks completely overwhelming a system that is built for a fraction of the number of samples at a level of precision that is really required for diagnostic and court-related work. We're not talking about that. When we talk about community drug checking, it's much more of a public health-based approach or harm reduction-based approach, where any information is helpful information, provided it's valid, and that we can get through field-based tools that exist. Probably you're familiar with many of them. Fentanyl test strips are a good example, and we know that we can train people with not chemistry degrees and who are not in a laboratory environment or who are not law enforcement in the field to be able to use test strips and other drug checking machinery. And that kind of consumer safety approach is a proven one for nutrition as well as for drugs. And so as we think about prevention and kind of the next wave of how we can help consumer safety, that's important. So that's community drug checking. So the next slide. is to summarize really that because we know that technology exists, that people can learn about the contents of drugs and the data can help people to stay safe. This same information can also be useful as we aggregate it and learn to help inform public health to better respond to trends in the drug supply. And so if we can break open access to the technology of drug checking in the community, then we have a whole different set of tools to work with and a set of responses that can be helpful. So the next slide. But just in deference to the request, we don't see that there is any particular population that is more helped or less helped with drug checking. It's just a lot like, nutrition facts on the back of a cereal box is really helped by a teacher, a parent, a consumer child, a consumer adult, as well as the public health entities. So I think this kind of level of information and a strategy that liberalizes access to that information allows for the most helpful information to all of the special populations listed there and to anyone else on this call for that matter. Yeah. The next slide. We did brought a couple of slides from other conversations and other presentations, but ironically, we're doing a drug checking training downstairs right now with 30 people in 3 different states. And some of these same examples are starting to come up as people are talking about how they're using the data. So one of the programs are actually downstairs. Their manager reported back and shared kind of a summary of how they've been using the data they used to inform participants of trends, to monitor above average fentanyl surges in their community, and then to tailor and pivot their outreach. And that on a programmatic level is really important. They also described new partnerships and new demographics of people who are using drugs. In their case, it was a population they weren't necessarily seeing coming into their syringe service program, or in this case, they didn't have as well-developed a Spanish-speaking program, and different parts of the city that had, they didn't have, we could look at the zip codes and see those individuals were not coming into their services, but now they are. So it's a really important set of connecting new existing harm reduction services and materials with a service and a set of information that's potentially helpful for at that local level. Some more diversity and more reach rather. Including routes of administration, smoking or snorting, folks who may not come into a syringe service program for existing services, but are motivated with these data to understand what might be in the drugs that they're snorting or smoking. The next slide. We've kind of built out a platform because people like to also interact with the data at that aggregate level, but also at their site. We built a platform called streetcheck.org. We again built that off of CDC and SAMHSA funding and some state funding. We tracked use of the data in aggregate. You can sort of look at trends in xylazine, for instance. These are kind of the FAQs, the most popular kind of inquiries that people would say, could you look and tell me what's the major drugs that are circulating in our community? So people can interact with the tool of streetcheck.org and also download their aggregate data for counts at their community level. And the programs and states, for that matter, can decide what is shared and the kind of information it may be useful, for instance, in a task force meeting or other metric setting and things like this. So next slide. It's a little deeper dive in what that might look like. Not having interactive slides, this is what it would be. So if on Massachusetts, when we sign on, we see our own dashboard for our state and sort of the different programs that are collecting information, and as they've been doing that over time, so they can see how they're doing. But they also, they can see both on the Massachusetts side, and then there's some public facing. This is an example of the public facing presence of xylazine and the samples over time. And you can interact with like, oh, if you want to look at, is it just in opioids? In the location and even further down to the town level. So that's a kind of example of interacting with data. Once data come in at a sufficient number of samples, you can do a lot more with understanding. So this was, for instance, the way we were able to see that about a third of the drug supply of the opioid drug supply in Massachusetts has xylazine contained in it. And then we can go and look a little bit more deeply, like how much xylazine is in it as a next step. So next slide.
Hey, Dr. Green, really quick.
Oh yeah, sure.
If you don't mind. So I am shocked that xylazine was that high of a percentage of the batches. I thought it was a much smaller percentage based on more on anecdotal data. So that's really, really interesting, that information that you have there. And then secondly, I think you're already anticipating, because it sounds like we don't know the quantity of xylazine in the samples. We just know that it was present. Is that fair to say?
That's correct. This, that next set of questions of like just how much, like per weight, how much xylazine. So this is like of all the samples, what's present. And that next set of questions was, we were really hungry for that information. Only one of the labs that we're aware of that we're working with, perhaps there will be others in the near future, but can quantify that, because it takes a very, it takes two things. It takes a balance that is very precise. And it also takes the willingness of the participant or the sample to be sufficient quantity. So that's usually 5 or 10 milligrams, which sounds like a small amount. It's about half a grain of rice, or a quarter to a half a grain of rice. But for since we collect remnant drug, not all the samples that come to us have that. I mean, it's still like, that's a substantial amount, all things considered. It's not like a dried cooker that has, where we scrape and we can test that little amount. But this would be trying to find folks who are willing to donate that level of a sample. So when we get those, and admittedly, our project works also with police departments that provide non-criminal samples to us. So from a fatal or non-fatal overdose or a controlled buy, those often there's plenty of weight, if you will, sadly, like the controlled buy was sufficient amount that we could, or if it was found. And in that case, we can submit those and sufficient quantity, quantify it. And it's really good, good question, because it's sort of the next stage. Like then, so that I can tell you, we've had in a couple that we probably have about 300 samples now with quantification for xylazine. And there's absolutely a range. There are some communities where it is hovering around 3 to 5% weight, and then others where we're seeing 20, 25% weight. I can tell you Philly is between 25 and 40. So at least for epidemiologically, if we're thinking about what is causing risk, it suggests that it's dose. If you have a lot of xylazine, you may risk having a lot more health effects. A little xylazine, we don't know surely like what that level is, but it does seem to suggest that more xylazine in the drug supply, the potentially more problematic. Starting to go one more thing, which is, we don't actually have to wait. One great thing about the FTIR, and we can talk a little bit about the instruments themselves, but the real-time drug checking that you can do with an FTIR, it struggles with low levels when it's below 5% of a substance. So fentanyl is oftentimes, unless it's a very, some places have 5 to 10% fentanyl. Because of international controls, fentanyl synthesis was getting worse and worse. And so we get a lot less fentanyl in our samples. So we're getting now 1-2% fentanyl, barely enough for people to not be in withdrawal. It'd be very, very, very hard to see on an FTIR. So a test strip is where we would rely upon that fentanyl was actually present. So if we don't see it, this is exactly the opposite with xylazine, because there's more xylazine weight on it. So there tends to be more than 5%. So if it's trace, we probably won't see it, and a test strip would be helpful. But actually a higher level of xylazine, which is what we're starting to see in most places, we will absolutely see it on an FTIR with training. But it gives you a sense of like, if you only can see it on a test strip and you can't see it on the FTIR, we back into the conclusion that like it's probably, probably smaller than, trace or a minor component. If it's on a xylazine test strip and on the machine, it's at least 5%, and it could be more than that. So please, be cautious and take a wound care kit as sort of a conversation. So it's imprecise. I wish we had a tool that could do all the things really easily and very quickly, but these are what we have, and it's more than we've ever had in our field and our communities. So, and really, what do people do with the data? That was the sort of next step of, because we're funded by the health department, we took it upon there was a real want to do things like alerts. Some places are very, depending on the state, some places they want an alert on everything. That's very much what's happening in Canada right now. In Massachusetts, the bar was very high for an alert. And so xylazine started out as there might be something that we're starting to see more xylazine. This was 2 years ago. We sent out a bulletin like informationally. And then last summer, we saw so much xylazine in so many places that we put this alert out. And we did a couple different versions. In the top left corner is kind of plain language, more visuals, and that got translated into 7 languages, the 7 dominant languages in Massachusetts. So the example of is the Khmer one for the Cambodian community in the middle there. And then to the right is the one that we created for providers, so our harm reduction providers and clinicians, a little bit more technical language, a little bit more specifics on intervention. The one on the sorry, I beg your pardon. That's the one on the bottom left, a lot more text. The top right is was set for our first responders, so our EMS and police. And that language is we've developed with some of the first responder advisors who suggested different kinds of verbs, different kinds of focus for what a law enforcement or EMS professional might want to know first and foremost, but from all like driven by the harm reduction content. And then those other 2 examples are just fun ones and really great creative translations, if you will, of the information that we shared into what one site in Western Mass and one site in Lynn, Massachusetts created based on their version of what they wanted their participants to know.
Dr. Green, this is Deputy Attorney General Becker. Just a quick clarifying question. Xylazine is the stuff that they call trank.
Yes.
That is mixed in and really creating like the flesh-eating symptoms at the injection site and things like that, correct?
Yeah, very painful wounds that start to get some necrotizing around the edges and stuff. And indeed, it's very painful. And you know, the importance, I think, of early detection and then early treatment, keeping things wet and keeping things covered. They heal. They actually, you know, they heal actually pretty well, but they definitely need some level of attention. And that can be through a harm reduction or other healthcare professional. But a lot of people may not be able to or want to go to a hospital or an emergency department. So these like extra hospital environments that are really taking on a lot. So finding things sooner and getting people comfortable and trusting will help. Unfortunately, we just don't know a lot of the science of like, is it a little bit of xylazine that causes this? Is it like a little bit of xylazine with an underlying health problem? You know, kind of like COVID in many regards, where it was like many people don't have a severe, but some people have really severe situations when exposed. So we're not totally understanding it yet.
Yeah, just from the little bit I've seen, it seems like once it happens and the person has been treated by EMS at the scene or at the hospital and released, that they don't, it's the aftercare and their openness to the elements and lack of ability to get clean bandages and stay properly wet or dry and things like that, that kind of just make the situation spiral and spiral, you know, depending on the person, of course.
Yes, I think you're spot on. And I think that the, you know, housing and some sort of safe space where people can have good access to, you know, clean water and not be exposed to elements, I think will definitely help in the healing. And the key component of xylazine, because it's a sedative meant for large animals, we absolutely see sedation can be a very long time. So that acute experience of sedation and worrying about people who may be outside, either exposed to sun, exposed to in our area like a cold, we worry about those sort of elements as well as how they fall. If there's, you know, with a lot of xylazine, people could be down and not moving for many hours. That's not good for, I mean, mostly when we sleep, we move around an awful lot, but with full sedation, purposefully as a, you know, for surgical, like you don't want the, you know, the movement. So these things are things that each community kind of addresses on its own differently, but we can expect sedation and sedation related, over sedation related concerns. And then the other piece is the wound, and related is the overdose, you know, complicating the overdose with knowing that naloxone, too much naloxone will bring on precipitated withdrawal when the xylazine does wear off. But in the meantime, making sure to watch their breathing and give enough naloxone that the fentanyl won't cause more harm to them.
Dr. Green, I'm so sorry to interrupt. We only have about 1 minute left until we
no problem. I want to make sure to get to all your questions too. So actually the next slide, and just kind of head into the other thoughts really for you all to think about. Geography, these devices are really important. And I think rural areas in particular, even in Massachusetts, we've been sort of thinking about the more drug checking can be in those rural areas, actually, the better. If you have rural sites doing harm reduction, do not leave them out. There's both kind of mail-based approaches, but also MAIL, that is mail-based approaches, but also that the machines are extremely durable and can be moved. Training needs to be on site, but also remote is totally possible. This is a workforce and staffing consideration, like thinking about equipping the community with sufficient number so that it takes time. So you don't want to have folks off at first line work if they have to always be in an office space, working with machines. So making sure it's sufficiently supported. And then the instruments themselves, they run about $50,000 for the machines that we work with. And then test strips, as you know, are about $1 each. Xylazine probably double that. So thinking about that, plus if confirmatory, or what we call offsite laboratory testing, that gets into which kind of fentanyl analog was it? Not just was it a fentanyl analog, but if that is interesting and important. We test 100% of all the samples in a lab. Some states have do a more random sample, kind of work with what you got. I'd be happy to talk about sampling frame if you want to think about, we only have $20,000 or we have $200,000. So those are some considerations. They are gaps kind of going into it. And then the last slide, I think, is just set of recommendations for you all to consider. But absolutely, I think the time is now for drug checking, really to help at the ground floor, planning think statewide, working with the harm reduction community to identify both partners and locations. We've always worked with, we've come to really like working with mail-based testing and piloting on-site drug checking in a subset of those early adopters. Some places are not ready, and I think that having an honest conversation, but building a vision that's statewide would be great. We do all that data collection, standardizing through that Street Check website. It has a collector tool on the back end. It's free. We're happy to share it. And it allows for people to kind of organize it. It gets kind of messy really fast with lots of Google Sheets otherwise, or other RedCap, or you pick the whatever. There's just a lot of moving parts. So we tried to recognize that and find a place that could be transparent and easy to use. And then just thinking about the principles and plans for what you think will happen next with the data. People really want to know, you're not collecting information from me. It's about the sample. What's the sample? Where's this information going to go? And being really thoughtful about that. So those are some recommendations from our work, and I'd be happy to answer anything you have we haven't addressed.
This was a really phenomenal presentation, Dr. Green. You can see there's so much excitement with the folks on the call. I think Debbie has a question that I just saw her. She didn't have a raise hand. And then Mr. Schoen, you have a question. I have a question as well. So Debbie, if you're able to unmute and ask your question.
Thank you. Thank you, Jessica. I'm sorry I'm late. I do have just one question, and you probably addressed it. I am hearing, and I don't know if this is true or not, but if there is xylazine mixed in with the fentanyl or whatever other drug, that Narcan does not work or work as effectively in saving a life. Is this true or not?
It is. Sorry. It's both. It is true because xylazine isn't an opioid. So far, there's some small laboratory work suggesting that it may work in a little way, but not in the way that like fentanyl, naloxone fits very quickly on the opioid receptors in the brain and knocks the fentanyl off. Like it doesn't have that key and lock perfect fit because it's not an opioid. But I will say, what we always encourage is administer the naloxone as you would in a suspected overdose anyway, because it's oftentimes there's an opioid on board, and the opioid will will move very quickly to a respiratory depression and potential death. So it's always better to address that. And then if you can, if breathing is still happening, but they may not be able to be responding in the way that you'd sort of expect after an opioid only overdose, that they still may be very sedated and non-responsive. But checking the breathing at that point, listening real hard, and rescue breathing if the breathing gets too low, and of course moving to a hospital or ED setting would be important. But the naloxone will, in some ways, it looks like it's not working. Naloxone is like miraculous in that if there's an opioid on board, it's going to do something. It's going to help that, but they may not still be responding and speaking or vomiting or responding in a way that you'd expect after an opioid only overdose.
Thank you. I'm sorry, just one more part to that question. So is there a fast test if they are brought to the hospital, they are saved? Is there some kind of rapid test that will show that they also have xylazine in their system? And you probably talked about this. I'm sorry, last question.
No. There aren't a lot of hospitals and emergency departments don't tend to test for xylazine. It's usually a send out. So they may pull it, they may pull, a biologic sample from the person that they won't necessarily be able to tell on the site. It depends on if the lab at the hospital already has xylazine and is doing this routinely, but oftentimes it's not in that routine set. So they'll send it out. So it may be days later that confirmation that there was xylazine that the person had taken. You may not know. There's a policy suggestion there to potentially require or encourage or strongly encourage or set a standard that includes xylazine as we include fentanyl and other illicit substances that in a panel for hospitals. I don't know what the cost impacts are though that's the only thing that I would probably just take a look into. Hopefully we'll have xylazine test strips, but I know most EDs and hospitals won't just take a xylazine test strip result. They'll want to confirm that the person actually took it. So those are only tricky things.
Thank you, Dr. Green. Oh, yeah. Mr. Schoen?
Sure, thank you. Dr. Green, I really appreciate your presentation and really understand, have a better understanding of why it's important to surveil the drug supply as it's coming through, so we have an idea of the trends. My motivating factor, and maybe I want to test out this idea and see if it's just a fantasy, will never happen. But the more that we can democratize access to instantaneous data, like if I'm a user, I have a batch, I could test it rather than waiting. That's, I think, going to give us our best results for public safety, because then I can know whether or not I should move forward to that batch or not. So I think about how can we make this ubiquitous, and I don't even know if it's possible because I don't know enough about chemistry to know if it's possible. But could you have like an iPhone and a little sipping straw that you put into the drug supply and it can sort of analyze it? I mean, is that even in the realm of possibility, or is it much more sophisticated than I'm possibly imagining?
There are all sorts of ideas. I appreciate your innovation and some really, and your ideas are definitely circulating in the collection of people trying to think about how do we make it even easier and more accessible. And because I think the test strips have been really helpful in getting people to think that they can do more drug checking in their communities and on their own and situationally. And the challenge, I think, is still like the more complex, the more things we want to know, it's really, what do people want to know? If they only want to know the active drug, or sometimes they want to know what the other cuts are. They may be, allergic to something or reacting to something, or, and those other additional pieces of information. So a lot of that conversation happens at the programmatic side, and then we can get the information to the person right there. But I think for the future, sounds very exciting to have technologies like that. I don't think we're close. The couple things I've seen are still a little farther away. Or they require quite a lot of drug. I've been working with one sample that like a paper-based one that's been testing like 12 at a time, but you have to put like a wad of powder and squish it apart. And I'm like, that's not going to go over well. That's a lot of drug to put through. It might work in a law enforcement environment, but then it sort of like moves, to your point about democratizing, it moves it farther into like back to the subset of people who had those tools to begin with. So, but I think the future is bright, and there's, sort of really interesting innovations on the commercial side or the nonprofit side or academic side that could really be exciting to inspire. And certainly right now, the tools, I don't mean at all to be suggesting that the only ones that we're working with are the only ones that are available, but it has been helpful to have some of the same language and working with the same tools so that we could kind of learn together, because it isn't something that, as people learn through chemistry, like they don't regularly learn about drug checking and in harm reduction, like they don't regularly learn about chemistry and spectral analysis. So in between, we sort of find ways of being able to exchange, and that part's been really fun and interdisciplinary and stuff. So, but I think you're right. We'll see new innovations like that. Hopefully more to come.
Okay, thanks so much.
Wonderful. Thank you so much, Dr. Green. Ms. Rodriguez, in the interest of time, I'll yield my questions for the agenda. Hopefully I can follow up offline about those. But join me in giving Dr. Green a round of applause. Thank you for joining us today. This presentation was very informative and very timely for our team in Nevada. So I'm really grateful for that.
Thank you. Until next time, then.
Until next time, absolutely. With that, I'd like to move on to agenda item number 5. We have a presentation on the DEA community outreach from Ruth Morales, who's joining us as the community outreach specialist for the DEA. This was a request from Ms. Nadler and one of her recommendations. So Ruth, the floor is yours.
Hi, Jessica. Thank you so much for that introduction. Good morning, everyone. My name is Ruth Morales, and I'm here to talk about a little bit about the DEA's resources that we have. And I'll try to go as quickly as I can. My contact information will be at the end. Feel free to contact me if I miss anything or you want more information. Next slide. Doesn't look like my first slide.
Sorry, just give me one moment, Ruth. I'm only seeing one. Sorry, just give me one moment.
You're fine. So while Emma's doing that, I'll just give a little background on what I do. So I am the community outreach specialist. I started off with DEA as a contractor and focused on the 360 program, then moved over to the diversion program, which I focus on take back and anything diversion related, meaning we would focus on registrants and making sure that they're compliant. And we would do trainings and educations for them to making sure that they're not overprescribing and practicing legitimately. And now I'm the community outreach specialist. I work primarily directly with Drug Enforcement Administration, doing their Operation Engage and also other division efforts. What I could do, Emma, is I can just start on my presentation from what I know.
Yep, I'm just about to pull it up. Sorry, I'm just going to pull up the ones that, yeah, go ahead and get started. I'm going to pull it up in 2 seconds.
Great. So what DEA is primarily known for is with enforcement, right? Special agents investigate illegal drug manufacturing, trafficking, and distributing of drugs, such as cocaine, heroin, and ecstasy. And also we're seeing now fentanyl. But on the flip side, we also have diversion control division, kind of what I mentioned right now about making sure that doctors or anybody who has a DEA registrant is actually prescribing for a legitimate purpose and not selling or prescribing out of practice. Before I go into the next slide, I just wanted to mention that diversion control also has an outreach portion. As I mentioned, we do the take back program and also do educational sessions for providers, making sure that they're compliant and making sure they're up to date with what they're supposed to be doing. Next slide. Just for some content, the Los Angeles Field Division is one of the second largest division for DEA. New York, I'm assuming, is the first one. And then these are the areas that we oversee, which include Nevada. Next slide. So one of the main points that I wanted to address today was our Operation Engage. Prior to Operation Engage, it was what was called 360. 360 focus on opioid specific, which now Operation Engage focuses more on a target focus within each division on what they see their drug threat is. It's a very comprehensive approach. It's where we work with different stakeholders in the community to make a difference. This program typically is a multi-year approach or multi-year program. It's not meant to last forever. So we really tap into and work with local entities like community-based organizations, local agencies to really sustain the programs that we come in and help and assist. And again, that's because this program typically moves from city to city. We really want the local stakeholders to be able to sustain this program. So what this looks like is we work with adults, youth, media, school, workplace engagement, again, to really kind of fill all the pieces that we need in bringing more awareness and prevention when it comes to drug-related issues. Next slide. We also have our One Pill Can Kill campaign. This was created in about 2020, 2021, when really we saw the increase of fentanyl poisoning and fentanyl overdoses. And we really saw that there was something that we needed to bring out to the community and to parents and really educate on what's going on and bringing awareness to pills. Now, this campaign has a multi-dimensional materials where you can use for social media, fact sheets, press release, graphs, PSAs, and videos. And this information is constantly developing and it's constantly changing because we see that, you know, things change in the community. So we have to constantly change as how things progress as well. If you would like more information on this specific campaign, you can check out dea.gov/1pill. Next slide. So these are some of the handouts or the fact sheets that we have online. We also print these out and we take them to community events just to, again, spread awareness. And anybody can download this and use in their communities and share the information. We know that we can't work by ourselves. We really need community organizations and just people in the community that can share the message and bring more awareness to fentanyl awareness. Next slide. So one of the newer things that we've been doing is the Family Summit. The first Family Summit took place in June of 2022 in our headquarters location, in which we invited families who had lost loved ones to the overdose epidemic, including fentanyl and any other drug. And it was a very hands-on experience for the families. As I mentioned, this is something fairly new that we've taken on because, again, we see the importance of bringing families who have lost a loved one to the conversation of how we can support them and they can support us as well. And in November, we actually had one here in Los Angeles where we had a similar layout of what was discussed. And some of those included advocacy, prevention, awareness, and I believe it was media. Again, to be able to give to families the resources that we have here locally, but also have an opportunity where they can share their story and also connect with parents who unfortunately have lost a loved one. So we are looking to possibly have another one. We haven't decided yet the date, if it's going to be in headquarters or if it's going to be here in Los Angeles. But again, DEA really sees the importance of bringing families together and having them at the table and having these discussions. Next slide. So one of our yearly resources that we have is Red Ribbon Week. I'm sure some of you might be familiar with it. It's celebrated in October, and it just began after the death of Agent Kiki Camarena. And we really saw how the communities can be involved in something like this. You can go to the next slide. And there's different opportunities where the community can come together, where cities can come together. On the far left, we have a building that went red for Red Ribbon Week. When Vegas had a 360, when Vegas was a 360 city, I believe they had City Hall go red as well. So again, this is something if you're in contact with businesses in Las Vegas or in Nevada that want to go red for the week, that's something that you can show your support. On the far right, we have the patch, which is for Boy Scouts, Girl Scouts, and that really is to empower youth to do a drug-free activity and support drug, to bring awareness to drug awareness. And we are able to provide them with those patches as well. And we have something for college students if they want to participate in a campus video PSA. We have all this information on our DEA website. But again, we really try to bring as much resources and as much involvement from all ages. We do events at elementary schools for students so they can pledge to be drug-free. And, as much information that we can give, if anybody needs any ribbons, I can also send those as well. We typically have a large supply that we pretty much distribute to anybody that's interested in having them. Next slide. And lastly, Operation Prevention. This is a tool that was created in 2016, and it was a partnership with Discovery Education. I personally like this curriculum. There's a tool where you can download for educators, school educators, if they need a curriculum for their students or want to be able to provide more information on positive living or healthy living. There's also a parent toolkit. I also really provide this for parents. It helps them have those conversations with their students or with their kids if they don't know how to do so, or also just learn more about the science of addiction and so on and so forth. It's provided in English and Spanish, and it also has now a counterfeit module where parents can learn that about as well. Next slide, and I believe that's it. I try to go as fast as I can. And I'll just leave you with a couple more of DEA resources: justthinktwice.gov, Get Smart About Drugs, Operation Prevention. And again, all these, Just Think Twice and Get Smart About Drugs has other resources of not just fentanyl, but also other drugs that we're seeing in the communities as well. And if you're interested in learning more about DEA as a whole, follow us on Instagram. That's where we really post what we're doing in the community and what we're doing with enforcement.
Wonderful. Thank you so much, Ms. Morales, for your presentation today. I personally feel much more educated about all of these different areas. We appreciate you joining us. I'm looking to my committee members to see if there are any questions on the presentation. Ms. Nadler, go ahead. If you're
Yeah, I'm here. I'm sorry, it's messed up. Thank you so much for speaking. I just want to say that I went to the summit, and if anything was the most informative thing I ever went to, this was it. I feel it would be a great benefit to have this here in our city and our state. It's just a plethora of information, and it's so wonderful for the kids, the program that they have. Thank you. Thank you, Ruth.
Thank you, Debbie. I appreciate that. And I know even though we don't have a community outreach specialist in Vegas, I kind of oversee the division, but I know the Las Vegas office is working on doing some type of youth summit. I don't have the dates on me yet, but I could definitely share that with you once I know. I know they're working to bring that to the community.
Thank you. Thank you.
Yeah, wonderful. Thank you so much. I do have a question, but I just want to make sure Mr. Schoen and Ms. Nichols don't have any burning questions on their end.
No questions for me. Thank you.
Thank you. All right, I'll go ahead and ask my question really quick. Thank you so much. So I just wanted to confirm, so it sounds like if you can clarify the DEA 360 program was sunsetted. I don't know what the past tense of that word is, sunset. And now folks are engaging with the Operation Prevention to have sort of similar materials or similar information for community. Can you talk a little bit more about that?
Yeah, so DEA 360 turned into Operation Engage, and that was selected by a number of things, by headquarters, but also by the divisions focused on the threat assessment of where they wanted to have Operation Engage. So right now it's in Los Angeles, but that doesn't necessarily mean it's going to stay in Los Angeles. Maybe a year or two from now, I might switch to Las Vegas. So it really depends on what leadership seems the focus, and then also data focus on where the threats are.
Okay, terrific. Thank you for clarifying that. I know there's been some confusion in the community here, at least, about where 360 went. So that's really helpful information. And then I just want to state for the record, I know we've been working with our new, I think, special agent in charge here at the community level, who's been really terrific on some of the efforts. I know he's been working with our prevention coalitions and some of the other advocates. So really grateful for his work.
That's great. I'm glad you guys are all connected.
Yeah, wonderful. Any other questions for the committee for Ms. Morales? All right, hearing and seeing none, I just want to thank you again for preparing your presentation and coming today to educate our committee about the work that you're doing. We really appreciate it.
Thank you for having me.
All right, wonderful. I would like to move on to, oh, Emma, you're in notes mode, if that's helpful. I don't know if you can switch. Okay, move on to agenda item number 6, a presentation on alcohol outlet density report. This was a request from myself, Chair Johnson, and I'll turn it over to Jamie Ross, Executive Director for Impact Coalition. Jamie, the floor is yours.
Thank you so much. Actually, if it's okay, Anne Elizabeth and I will be tag teaming this as well. Emma, did you want to pull the presentation up?
Yep, I'm trying to get it so it shares on the right screen. I apologize. Is it still showing notes mode for you all?
Nope, it's
Okay.
perfect now.
Great. Thank you, everybody.
Thank you so much. And apologies, Anne Elizabeth and I put this together as one PowerPoint presentation, and Emma was kind enough to separate it into 2. So thank you so much. I'm Jamie Ross. I'm the Executive Director of the PACT Coalition, and I believe Anne Elizabeth is on as well.
I am on. Hi, everybody. Thank you for the opportunity to present. I'm Anne Elizabeth. I'm the Executive Director of Join Together Northern Nevada. We serve Washoe County.
Next slide, please. Anne Elizabeth, I'll let you chat about this one.
Perfect. Okay, so alcohol outlet density is the number and location of places that sell alcohol in a community. And just to sort of situate us, when we're talking about these numbers, we're talking about on-premise and off-premise. And so on-premise looks like our bars and things like that. Off-premise looks like the grab-and-go liquor stores that we see in our communities. I added alcohol delivery to this. I was doing some research on alcohol density in preparation for this meeting. And alcohol delivery, of course, is changing the landscape of consumption. And so I threw that on there to talk about. It's not currently included in alcohol outlet densities because those alcohol delivery services are coming from our current outlets. But I think it's an interesting thing to think about as we think about alcohol outlet density. So the reason that this matters to us today is that it's correlated to a lot of risk factors and a lot of things that are going on in our community that contribute to substance misuse across the board. So of course, increased alcohol use is associated with outlet density, increased violence, domestic violence, and street violence. Alcohol outlet density is occurring in those lower socioeconomic areas. That's a marketing tactic that's been utilized for many years by the alcohol industry and more familiarly, I think, with the cigarette and tobacco industry, right? In those low income, low socioeconomic areas of use. And so of course that impacts social determinants of health. And we see that health equity being really impacted by density across the board. And so those are some of the major reasons why we care about this. It also, of course, increases access, so underage use increases. And then for this group, increased overdose rates are associated with alcohol density. And we'll get into that a little bit more as we go forward into the presentation. But I think it's important to note that drug use is related, right? So alcohol use is related to overdose rates and underage use of drugs across the board. And so that's important to us. And lastly, but certainly not least, alcohol outlet density is associated with that increased child abuse and neglect. And so we see ACEs, adverse childhood experiences, which is a major risk factor that we talk about when we're talking about substance misuse prevention with our young people and being able to mitigate trauma. And I'll pass it, Jamie, if you wanted to add anything, go ahead.
No, I think that is wonderful. In 2020, we were able to compare alcohol outlet density. Unfortunately, the map that we used, the GIS mapping, has disappeared. But if you overlay alcohol outlet density with cannabis dispensary outlet density, unsurprisingly, the hotspots are very, very, very similar. Again, correlating to all of these other socioeconomic and health disparity issues. And that's all I have to add.
Great. And thank you for moving the slides forward as well as that alcohol density. when I'm looking at the research that's being done, and this is national research, there's an approximately a 16% increase in neighborhood overdose rates for each additional alcohol outlet. So you can see that strong correlation between the two occurring. Something interesting as I was looking at the 2020 data is that there has been a reduction in Nevada density over the last 3 years prior to 2020. And so when we look at this data, as many of you know, we can see that it's been impacted by COVID-19 and some of those delivery rates and less licensing and things like that going on. So it'll be interesting to look at that data over the next few years. I did provide for you there the mapping. So the map on your left-hand side of your screen is the OD maps through the AG's office. And so you can see where those hot areas are. And then if you're looking, it's a little bit hard to see, but if you're looking on the right-hand side, you can see that the more dense the alcohol outlets are, coincides with that heat map. And that's in the Las Vegas area. It's pretty easy to correlate the two with that, but I thought it was a nice visual representation of what we're talking about with outlet density and overdose. Policy work can be done around this. Of course, we know that limiting licenses or deciding how many licenses in particular areas works well in policy work. Alcohol taxes work well in policy work. I was just looking at, this is sort of an offshoot, but I was just looking at DC. I was there for a conference in January and there's hardly any liquor outlets. And so taking a look at, what their policies are and how we can change the scape of what we're looking at with alcohol density can have an impact not only on youth use, but on overdose rates across the state. Thank you.
And here are the resources. All of these are live links. If you've got any additional questions for us about alcohol outlet density, this is really a basic primer on why this matters. And we realize that the SURG is multidisciplinary, focusing on more than just opioids, but we also know that opioids is still very much the topic that everyone on a national level is focusing on. So we wanted to make sure to be able to tie all of that together. But what we do know is alcohol is still killing more people than any other drug, including opioids. It's just killing them much more slowly. So that is not something that we like to talk about as a nation.
Thank you to Jamie and Anne Elizabeth for a great primer on alcohol outlet density. I don't know if my committee has any initial questions on this presentation before we talk about prevention programming. Ms. Nadler, recognize you for a question.
Thank you so much on bringing up alcohol. We don't hear it talked a lot about, and it absolutely is. I have a question for you, though, on the opening statement where you're saying it's attributed or it's happening in lower socioeconomic places. I'm seeing it, I guess it's just my view, but I'm seeing it in all the wealthy kids, like around areas of town. I see kids in BMWs drive up to 7-Elevens and ask people to go in and get them bottles. And I mean, I see it happening all over. So how I guess are you getting your numbers to show it's more in the lower socio? I'm not saying it right. I'm sorry, but the low levels, because I'm seeing very wealthy teenagers in high school just getting sloshed all over our city.
Yeah, thank you for the question, Debbie. I think obviously misuse is not discriminatory, right? So it's happening across populations. What we're seeing here is density, geographic density, right? So more outlets in the regions, and you can see that by the maps. Thank you for pulling that up. Sort of this middle left-hand side region of the right-hand side map. That was a confusing way to say that. The alcohol density map you can see those concentrations of alcohol outlets. So we're not really looking at that youth use across the board, right? We know that, but we're looking at how many outlets per geographic spatial
Gotcha.
region. Yeah.
Okay, thank you.
Yeah. Thank you. That's a great question.
Thank you for that point, though. I mean, I'm seeing it on the rise. I'm seeing the numbers across the country, and it's just, whoa. Thank you for bringing this up.
Thank you, Ms. Nadler, for your question. Other committee members, Mr. Schoen?
Yeah, Chair Johnson, thank you so much. For the record, Eric Schoen. Good afternoon, you two. Appreciate you guys making this presentation. As somebody who's been working in the addiction space for close to 25 years now, one of my pet peeves has always been that people take their eyes off of alcohol. Can't ignore the other emerging threats. I get that, but alcohol has been the workforce of destruction, societal destruction for a long time. And I appreciate you guys reminding us that we need to pay attention to alcohol. In fact, in rural Nevada, alcohol is still by far the #1 substance that we see most often used and abused and lead to tragic results. I am hoping, and I'll just say this, I'm not really expecting an answer unless you want to a response, but I'm hoping that some of the newest data that is showing that at any amount of alcohol, there's no such thing as a safe amount of alcohol. There's no such thing as a safe, I mean, in terms of use, they're now pretty, what I've seen the last few months, is that there's no beneficial amount of alcohol. I'm hoping that messaging starts to gain some traction, because I'm hoping something can kind of blunt this attraction that alcohol seems to have for people that want to use it. So thank you. I appreciate it.
Thank you, Mr. Schoen. Anne Elizabeth or Jamie, any response to that?
We agree. Just across the board. But I think, Eric, there's most of the things that we're going to be talking about we'll agree on.
Great. Thank you. I have one quick question for the team, if that's all right. Jessica Johnson, for the record. And Anne Elizabeth and Jamie, thank you so much. I am grateful that you were able to bring this. I would love to know, and perhaps this is something we could follow up with offline that we could send out to committee members. What are the barriers to regulations around alcohol outlet density? And do you have any kind of concrete, or are there best practice recommendations or policy recommendations that this committee could consider moving forward?
This is Jamie Ross for the record, and I can answer more for Clark County. So statewide in Nevada, alcohol is entirely regulated by the county. So there is nearly zero state level regulation. There is no state alcohol control board, which means every county is very different, and oftentimes every community within a county is different. I think as far as best practices go, things that we know on a federal level have worked in every other state have been limiting the amount of outlets, reducing all you can drink packages, reducing or eliminating happy hour specials, making sure that there is at least X number of miles between recreation centers, schools, etc., places where kids congregate, and alcohol outlets, ensuring that alcohol advertisements don't get to children. All of those are federal best practices, and most of them are not in statute in Nevada.
I didn't anticipate such a wonderful breadth of policy, Ms. Ross. Thank you so much. But I shouldn't be surprised. I really appreciate you sharing those best practice recommendations, and our committee will bring those up when we discuss this at our June meeting for consideration for review. So thank you. Any other questions on? Make sure I know where we're at. Agenda item number 6 before we move on to agenda item number 7. All right, hearing and seeing none, I will turn it back over to Ms. Roz and Ms. Northen to talk about a presentation on prevention programming in schools. This has been a topic of conversation of this committee on across the last year or so, with multiple folks being interested in what this prevention programming looks like. So Ms. Roz, Ms. Northen, over to you.
Thank you again, Jamie Ross for the record. And yeah, you can skip the first two slides and we can just jump into the third slide. I wanted to kind of give a really brief primer on prevention and programming in schools. We're going to be focusing not on every single program that happens, but on the programs that we know have the most evidence to support them. Our coalitions are oftentimes the ones who are doing the majority of the programming in schools, either through funding of school programs or through direct evidence-based programs in schools funded through the coalitions. And I want to be clear, I have had 3 conversations in the last 5 days with pretty high-level folks within our state about the fact that there's no prevention programming in schools. And I believe that, and when I say, what about XYZ? And they say, oh, when people think drug prevention, to use terms that we used in the 1990s, they think of DARE, they think of the Every 15 Minutes program, which brought the big car crash into the school. And what we know is the best prevention programming, the gold standard for prevention programming, is things that increase protective factors and decrease risk factors, that address adverse childhood experiences, that address the social determinants of health. So most prevention programming we're going to be talking about, if you talk to a teacher at a school, they would not at all correlate what we are doing to preventing youth substance use. They would think that these are classroom management tools, that these are helping them be better teachers, they're helping their students be better connected to their community, but they would not think that this is drug prevention circa 1995, because we have better evidence to suggest what works. And so I just wanted to talk about that also really quickly. It is in statute that there is a required 1 week of substance use prevention training that's given to every student in a health class statewide. It is not required to be evidence-based, but there is 1 week that every health class should be covering this. And that is all I have for that slide.
Okay, I'm going to jump in just a little bit and talk about prevention programs statewide. So I think it's really important to reiterate something that we already know, which is that substance misuse is a complex problem and requires complex solutions. So prevention isn't a one-size-fits-all students or all communities model. And so we see a variety of programs that are evidence-based, data-driven, statewide. The list that you have in front of you are several examples of this. I'm not going to read them off to you. We do a lot of neat things in our world, but I will draw your attention to a couple of things. As Jamie was saying, prevention work does look like behavior management. It does look like promoting life skills. It does look like resilience and coping mechanisms with kids. It is tied inexorably with mental health and suicide prevention and all of our other partners in this work that we do with public health. And so there are incredible programs going on in mindfulness in the state. And when I get done kind of going through these, I will have Jamie talk more about the mindfulness portions that are going on in our rural areas. It's an incredible program for our kiddos. Youth mentoring programs, peer-to-peer mentoring, getting the kids involved. And I think something that the coalitions do really well is that the concept of nothing about us without us, right? And so we work really closely with our community to develop a plan for programming and to do comprehensive community strategies with our community partners. And that's the magic of our coalition work and prevention within the coalitions, is that we have the ability to, as boots on the ground folks, work closely with a multitude of partners to resolve a lot of the complexities of what's going on with prevention in our schools. We, as a statewide coalition group, we do a statewide prevention summer camp. We bring youth together for that. And then, of course, we have out of the box programs as well. So positive action, life skills. This is not about drugs, catch my breath. All of those programs that address specific substance misuse needs as well. And we do this all in very close collaboration with our school district, which I'll talk a little bit more about when I talk about our particular programs in Washoe County.
So covering some of the programs specific in Clark County. There is the All Stars program that is an evidence-based program. For those of you who are from Vegas, this has nothing to do with after school All Stars. All Stars is a federal, it's on all of our federal registries for evidence-based prevention programs. It is either an after-school program attached to, say, theater or some sort of other after-school program, or it is actually can also be done as a semester-long in-class program. Positive Action is currently being piloted in 5 of our after-school safe key sites within the city of Las Vegas, and hopefully we'll be moving into city of Henderson as well. Too Good for Drugs. This year, CCSD Police is actually working towards putting that in 20 schools countywide. And if you talk to them, they will call it the LEADS program, but the evidence-based program that they're utilizing is Too Good for Drugs. This is not about drugs, is a single staff or single day presentation. What we know is single day presentations are not the best in changing long-term behavior. But what we often will do is, and this is statewide, we will use this if someone says, can you do a one-day presentation? And we will say yes, and we will do this, and then we will springboard that into getting more curriculum involved in their program. Positive Action is in most of our Boys and Girls Club in Southern Nevada as well as statewide. There's the SAAP program that's through CCSD. If a student is caught with drugs and or paraphernalia on campus, they are required to go through a 8 hours of training with CCSD teachers and the parents as well. And that's something that CCSD actually has in statute. It's often done in other counties as well, but within CCSD it's actually run through their program. Red Ribbon Week. As we heard the DEA speak about earlier, about 20 schools participate in that. Leader in Me is an elementary school program, as well as Catch My Breath. Catch My Breath is the only evidence-based program that is specifically vaping prevention. It has been utilized nationwide, and many programs here in Nevada are utilizing it. Next slide, please.
Thank you. Programs in Washoe County, you can see there's some mirror of what's going on in Clark, so I won't go into too much extra detail about those. I do want to mention our substance abuse prevention program through Washoe County School District, similar concept to what they're doing in Clark County, in that if a student is caught with paraphernalia or vaping in the bathroom, utilizing substances, they are required to go through that substance abuse program. Sometimes, depending on the circumstance, and if it's a multi-offense student, parents are also required to go to these classes, which is a great way to bring families together to have these conversations and find solutions. And these are led by school counseling staff. And so we work closely with their staff to assist and augment this programming and be able to provide additional referrals or assistance for families as they go through the SAP program. During COVID, we provided videos for that program so that it could be done virtually as well. We do direct service with Too Good for Drugs and are in the process of doing Train the Trainer across schools in Washoe County. We're very excited about this. This program is performing really well with statistically significant changes over time. And so right now we're serving a small population. We are serving 6 schools with that. And something that I want to mention while we're there is that all of this is scalable. So we're serving a small population because that's what we can do with the funding that we currently have. And our job is also to increase capacity by doing those train the trainers and assisting other people in bringing on this prevention into classrooms. Catch My Breath, Jamie talked a little bit about that. Vaping is a huge issue in our areas. We can see that by the data. It is important to be drug specific with that one. Oftentimes we talk about being universal with drug prevention programming because it works really well to do that. But this one is a nice vaping prevention program. It's free, it's open. Teachers can teach it. And so we enjoy doing Catch My Breath with the school district. We're engaging in Project Alert. It's another evidence-based program. It was a pilot this year for us. We had not done Project Alert before, so we tried it in one school. We were waiting on data results from that for our community. We also sub-grant out. So as Jamie had mentioned, us or our partners will do direct service. And so we are currently doing positive action with a nonprofit called Accept in our community and Boys and Girls Club of the Truckee Meadows. We support part of that program, but Boys and Girls Club of the Truckee Meadows is doing positive action across the board in schools, which is incredible capacity builder for this program. Mentoring is something that doesn't often get mentioned with prevention. It's another one of those ACEs mitigation strategies. And so we promote mentoring in our community with Big Brothers, Big Sisters of Northern Nevada. We also do Prevention Week and Red Ribbon Week activities. And we put on the School Mental Health Professional Development Day. So we serve approximately 250 professionals with this and making sure that youth serving folks are up to date on the latest trends, are able to have trauma-informed practices as they go through the school year and can help our kiddos out. I'm going to skip down to the bottom. I do want to mention Handle with Care. In our prevention programming in Washoe County, we facilitate the Handle with Care application, which is utilized by law enforcement and puts in a trauma report. Doesn't have a lot of information, has the child's name, and that something traumatic happened in the household associated with ACEs. That goes into our counseling department, and the teacher of that student is let know that they need to handle that child with care. And so this mitigates trauma response and has been an excellent program for Washoe County kiddos. Thank you.
Next slide, please, Emma. So strengths and challenges. So you've heard specific programs happening in the two most populous counties in Nevada. And one thing that we often get is when new funding comes out, it is, oh, what new programs can you do? Not how can you expand existing programming that we know works? The joy of what coalitions do is we really incubate and pilot programs so that they do become scalable and they can grow past the four walls of the coalition. But oftentimes when new funding becomes available, they don't want to fund existing things. They want to fund only new things, which means we're starting from scratch and trying to find new programming, not things that we already know work in our specific communities. So as funding becomes available, ensuring that it does allow for scalability of existing programs. Collaborations right now are ongoing with our multi-tiered systems of support. As Anna Elizabeth spoke, each coalition is really embedded in the school district in their respective areas. Obviously, Washoe and Clark are behemoths, but they are absolutely involved in intimate ways with their school districts, with the staff within their school districts. There's actually at least one county in Nevada where in statute or whatever written into the school charter is that the coalition in that school district will be the people who deliver prevention programming. Obviously in our smaller communities, that's a lot easier to do than our larger communities. And so relationship building obviously continues to be, I think, one of our #1 strengths, as well as a challenge ongoing because people don't seem to stay in a position for 30 years like they did 30 years ago. Next slide, please. And there's our contact information. And we are open to questions if you have any.
Thank you so much, Jamie and Anna Elizabeth. We have just a couple of minutes for questions so we can get to the rest of the agenda item. Debbie, I saw you come off of mute. Feel free and ask your question first. Thanks.
I'm so sorry. This is my passion. Y'all know it. Okay. Couple questions. Thank you so much for what you're doing. So I've written down a couple of questions. I'm sorry, I'm going to try to do this fast. I don't know if everybody's seen this, but I know you must have. Whippets and huffing have become very big, getting big across the country. I've had many reporters call me to ask me about it, and I wondered if we're addressing that issue, the huffing. The cartridges, whippets, they're becoming very big again. Several kids have died. That's number one. Number two, ID cards. I know Lisa Lee in Washoe County told me that when the students get ID cards in middle school and high school, on the back of the cards, there's emergency numbers for kids, suicide hotlines, drug resources. I mean, any kind of help is available. I've contacted the Nevada Department of Education and everybody about having those done in Southern Nevada. Y'all are doing so much in Washoe County. It's amazing. It's incredible. And I've called all the schools, and I know the schools I've called, there is nothing going on there. And as far as Red Ribbon Week here in Las Vegas, I was actually working with Marilyn Kilpatrick, I think, with the DEA for 360. And we were going to do a big one in 2019, and it was canceled. And then she was defunded. So I had contacted several schools, and I haven't seen Red Ribbon here. That's number three. There's also a program that I was working with Terry Kearns on well before COVID started, and it's called Choose Love. And the lady who did the program lost her son to I believe it was a Sandy Hook shooting, and she started a program, and it's free. It's across the country. It's called Choose Love, and we don't have it in our state. And it's more for elementary school, but it deals with everything, with the coping mechanisms, the social emotional learning, the mental health. I mean, as we know, that's so important. And then last of all, the programs that you're talking about, are these mandated? Do the schools have to do them? Because whenever I call Clark County School Board of Education, nothing's mandated. Everything is school choice. And I'm sorry, that's it. I know that was a mouthful.
This is Jamie Ross for the record, and I will try to answer as many of those questions as possible. Choose Love is not something I've heard of. We can definitely look at it and see if it's in some of those national registries. Just kind of so you understand how we choose which programs go where. There's a bunch of lists of national registries of things that nationwide have been proven to reduce youth substance use in the long run. So some of the ones that you'll hear nationwide: Positive Action, Life Skills, etc. So we can definitely check to see if that is on those lists, and if whomever created that program is looking to ensure that that gets added to the registry. I do know that in CCSD, the mental health hotline is on middle school ID cards. So I can, I'm unsure about high school, but I do know that it is on in high school. As far as the Red Ribbon Week is actually sent out through Rosa O'Bannon with Office of Safe and Drug-Free Schools through some funding that PACT receives through the state federal Substance Abuse Prevention Treatment Block Grant, 20% set aside for primary prevention. And we are actually able to work with about 20 schools to do that. And I can definitely get you that information when it does come out. We usually send it out in late August or early September for the October Prevention Week. I think I've covered most of your questions. If there was one that I missed, I apologize.
Sorry, thank you so much. The whippets, the huffing, it's become very big.
So yes, in most of all of those programs we spoke about, we're not talking about one specific drug. So most of the programs that we spoke on are not specific to one drug. To my knowledge, there is no evidence-based prevention that specifies or works only on inhalants. We do know that inhalants, just like any other drug, kind of ebb and flow. I remember this was a really big issue in the 90s. So it's not something that I have been told by our youth programs statewide, but I will definitely start asking about it. And seeing, we can also look at our death data and see in our hospitalization data to see, I think that's some folks at the health district may be good resources for that.
Okay, thank you so much. Thank you.
Great. Thank you so much for your questions. I know we have about 5 minutes. I had just one quick request for follow-up, if that's all right. Jamie and Anne Elizabeth, would you be able to share the links for our committee to review of where you locate those evidence-based prevention programs? I think being able to have access to that information would be helpful for committee members. And then I've received this question like 3 times in the last week, so I'm just going to ask it if that's okay. How do programs become evidence-based? You could summarize in like 1 minute.
So people who have much more expertise in this, national level experts, actually, there's an entire field of science about this. And if you're interested in that process, I would say that our local experts on that would either be Dr. Tim Grigsby at UNLV School of Public Health, or Alyssa O'Hare, who runs the 9th Region 9 PTTC. They can definitely answer that question better than I can, but basically it takes a whole long time and a whole lot of pilot programs kind of in multiple jurisdictions to ensure that each program is not just for youth in this one school where it happens to be really, really good, but it is replicable across the country. And I would recommend talking to one of them because they are much better at explaining that than I am.
Thank you.
Not a data person.
Thank you. Committee, join me in thanking Ms. Ross and Ms. Northam for an excellent double presentation today on some really important topics. Thank you both for your preparation and time. I really appreciate it.
Thank you so much. Have a great day. And we will get you the list of both the local or state and national registries.
Thank you. Ms. Rodriguez, I know we have about 3 minutes before our meeting adjourns, so hopefully I can move through these pieces quickly. We'll move on to agenda item number 8, which is the 2023 session legislative update. Ms. Rodriguez and team prepared these bills and information for us, so I'll have her just scroll through these slides for the committee. Please feel free to review and follow up if there are any additional questions. And there's a full list that was posted with the agenda items for today for anyone of interest. With that, we're going to move on to agenda item number 9. I had just a couple of quick pieces I wanted to say here, and then I'll have a minute for folks who may need some extra time. So this is an overview of the recommendations received and next steps. So since the last subcommittee meeting, there's been one recommendation received on increasing support for youth vaping prevention, submitted by myself, the chair. There's been a presentation scheduled at our July meeting by Malcolm Allo from the Tobacco Control Program at the Southern Nevada Health District. Also on our July meeting, we'll include a presentation from Joseph Engel and Ari Celli from There Is No Hero in Heroin, or TINHI, on adolescent peer support and prevention recommendations. That was a request of Ms. Nadler for a presentation. If you have any other presentation suggestions for the July meeting, I'm going to ask in the interest of time that you connect with Ms. Rodriguez, staff to this committee, as that will be a really helpful way for us to organize these pieces. I'm also going to ask committee members if there was something that you heard today that you would like to move forward on a recommendation for, that you complete the recommendation request form and send that in at our June 20th meeting, which I'll talk about in just a moment. We'll be collating all the recommendations that the subcommittee has received so far in preparation for the large full SURG committee meeting in July. And I want to be sure that we've gathered sort of the full breadth of ideas that have been vetted at this juncture. So if committee members could help us out and move that forward, that would be really beneficial. Our prevention subcommittee meeting is scheduled for June 20th at 2 p.m. The goal of that subcommittee meeting is going to be to further develop the harm reduction recommendations that were presented to the full SURG in April. Our committee is taking that on. So we'll review and incorporate that feedback and also review and discuss the recommendations to date from other SURG committee members in preparation for the full SURG meeting. I'm going to stop talking for a moment in case my committee members have any questions.
Chair Johnson, can I ask a question?
Yes, go ahead, Ms. Rodriguez.
Thank you. It's my understanding there wouldn't be any presentations at the June subcommittee meeting. It would be more of a workshop type meeting. I just wanted to clarify that that was
correct.
Okay.
Correct. Unless there's objections from the committee, I'd really like to use that opportunity to workshop sort of our status to date and make sure that we've collated sort of where we're at in preparation for the full SURG meeting.
Great, thank you.
Terrific. Ms. Rodriguez, are there any additional pieces to this agenda item that we've skipped over?
No, I did see that our DAG turned his camera on, so I'm wondering, Joel, is there anything that
I know this is the Attorney General Becker. For the record, I just want to make sure that we have time to open up for open comments before the meeting is adjourned.
Oh. Thank you. I'm seeing Ms. Nadler, do you mind hopping off of mute? We're not technically supposed to take any comments in the chat. I know you were having an issue with raising your hand.
Yeah, and we'll get to public comment in a.
I'm on mute. I just wondered if I could just put the link to the Choose Love for everybody to see in the chat. Is that possible or no?
Our DAG is giving the thumbs up on that, so that is an okay thing to do. Thank you. All right, wonderful. So those are where we're at with recommendations received. We're going to table the discussion of the report out for the July meeting to our June meeting. So I'm tabling agenda item number 10, and I'm going to move on to the period of public comment. So this is our final period of public comment. Limited to 3 minutes, can comment on any matter that is not specifically included on today's agenda, and no action may be taken upon a matter raised in public comment. I'll pause now in case folks have any public comment. Ms. Rodriguez, do we have anyone for public comment?
Chair Johnson, I don't see anybody indicating that they would like to provide public comment, and I just note that the link that Debbie shared we can include in the minutes, so that will be part of the record.
Thank you so much. All right, wonderful. With that, I'm going to move towards to agenda item number 12, which is adjournment. We are 3 minutes past the hour today. Thank you for everyone for staying on. This was a really information-rich meeting with a lot of really wonderful experts and excellent detail about issues that are relevant to our state for prevention. So thank you so much for everyone's engagement and for your time, and to the SEI committee, as always, for excellent organization. Thank you all. Have a great day. Meeting's adjourned.
Take care, everybody.
Awesome. Thank you.
Thanks, everybody.